Ο επόμενος ομιλητής είναι ο καθηγητής Φορτουνάτο από Ρώμη, που θα μας πει breast surgery in high risk setting. Professore, venga, se accomodi.
Okay. Thank you for your invitation. I'm very happy to be here in Athens today. I'm grateful to all my friends, Dr. Xapapadakis, sorry if I don't say the right way, Dr. Papadopoulos, the organization of this meeting. I understand very little the Greek, but I understand that you are a tremendous group of surgeons, oncologists, radiation therapists. I congratulate because I actually see the very high quality of this meeting, and resembles the some meetings that we have in Italy as well. So a difficult task today, the high risk setting. But I understand that there are many high risk settings. So last night I changed my presentations, and I would like in the agenda to introduce three topics. The first one is surgery in the triple negative cancer. The second one is for triple negative cancer, which advantages for surgery we have after neoadjuvant chemotherapy. And then I would like to touch base on breast surgery in women with BRCA mutation and cancer. And so the first question I have is, in case of diagnosis of a triple negative tumor, do we have any suggestion that we should do more aggressive surgery, or that a decreased implementation of breast conservation is on the agenda? And the first consideration is that local relapses are decreasing throughout our breast centers. And this is a very interesting study published 10 years ago. As you can see, by the year 2000, we have witnessed a tremendous decrease of local relapses, both for ER-positive and ER-negative disease. The second consideration is that indeed there are some tumors, like HER2 tumors and triple negative tumors, that are at higher risk of local relapse. And we have indeed a systematic review published 8 years ago on 11,000 patients, 7 studies, comparing triple negative disease versus luminal-like disease. And as you can see, the odds ratio for local relapse is 0.5. However, the increased risk of local relapse is more or less equivalent, both for breast conservation and mastectomy, as published in this systematic review of more than 12,000 cases. And as you can see, the increased risk of local relapse is more or less the same, both for breast conservation and for mastectomy. So that the true question is well addressed by this study. This was a MD Anderson Cancer Center study, 1,300 patients, in which stage by stage breast conservation and mastectomy yielded a similar overall survival and a similar local recurrence-free survival. And this is the bottom line. We can do more aggressive surgery, but we don't accomplish much in terms of local relapse, overall survival, and local relapse-free survival. This has been confirmed by Memorial Sloan Kettering study about 10 years ago, more or less the same number of patients of the MD Anderson, T1, T2. And as you can see, very low incidence of local recurrence in the triple negative settings after breast conservation, more or less the same as the mastectomy, and essentially equal overall survival and disease-free survival, to confirm that nowadays in the multidisciplinary approach of our disease, even very aggressive tumors like triple negative can be managed by local breast conservation. Indeed, even for women less than 40 years old and of age. And this is the true question. If you have triple negative disease, I assume, of course, BRCA negative, but of very young age, what is our approach? And this is well addressed by a Memorial Sloan Kettering study. And as you can see, about 2,000 patients. And as you can see, indeed, very young women have a higher incidence of distal recurrences, 17% versus 11%. But essentially, local relapses are the same, and regional relapses are the same. So indeed, these women are somewhat at a disadvantage, but local therapy can be the same. In the last few years, two meta-analyses, one with 1,800,000 patients, and another one with almost 1 million patients, have reviewed the issue of breast conservation and mastectomy. And what is coming up is that, well, breast conservation may not be equal, it may not be worse, but maybe can be better than mastectomy. Of course, most of these studies are retrospective, with all the biases of retrospective studies, but I found this quite interesting because the numbers are huge. And in a propensity score match analysis, lately, even for triple negative disease, a study of the SER database with 12,000 patients, 5,000 of them analyzed in a propensity score match analysis, demonstrated that breast conservation can be better than mastectomy for whatever reason. We don't know why, but it seems to be at least equal, maybe better than mastectomy. The second point that I would like to introduce in this lecture is what advantages we can have for neoadjuvant chemotherapy, particularly in the triple negative disease. And this slide shows the first advantage, particularly in case of PCR stratification according to the biological subtypes loses the statistical significance, and all tumors behave more or less in the same manner, and they behave very well in terms of local control. So PCR is extremely important. We all know about residual cancer burden, and we all know that residual cancer burden after neoadjuvant chemotherapy has a stronger correlation with survival. But it does have the same correlation even for local control, as demonstrated by this study. And as you can see, patients with PCR have a tremendous local control advantage, and these the local relapses increase by RCB. So the bottom line is, what happens after neoadjuvant chemotherapy? Should we do breast conservation or mastectomy? And a secondary analysis of the I-SPY 2 trial on almost 1,500 patients has demonstrated that if we stratify patients by RCB, 0, 1, and 2 and 3, breast conservation and mastectomy are equal. They have the same local recurrence-free survival. But what happens for triple negative real world? Actually, more than a real world, this is a secondary analysis of a randomized trial, the brightness trial, which I think has a tremendous interest for us. And this is their patients, about 78 of them were pre-neoadjuvant chemotherapy breast conservation eligible. Among these 22%, almost 50% became breast conservation eligible after neoadjuvant chemotherapy, so that you would expect that breast conservation would be employed in about 85–90% of patients. Instead, there was a decrease of implementation of breast conservation, and this happened regardless of PCR. So I think this is a very interesting point. Neoadjuvant chemotherapy, particularly in some settings, regardless of response, regardless of PCR, seems to be associated with an increase of mastectomy rate. The second point is what happens for patients with positive nodes who decide to, who have a major response, as we have seen multiple times today and yesterday. They can sterilize, lymph nodes can be sterilized after neoadjuvant chemotherapy. So I found very interesting to analyze this UBreast survey. We are talking about 350 surgeons, 45 patients around the globe. And the question was, you have a CM plus 1 to 3 lymph nodes positive who becomes after neoadjuvant chemotherapy YCN0. And the question, and the answer was 25% will still do an axillary lymph node dissection. The second question was, you have more than 3 lymph nodes positive, and they become negative after neoadjuvant chemotherapy. What would you do? About half of them would still do an axillary node dissection. So there are several reflections that we have to, several considerations that we have to make at this point. And the first one is, why is it still very important to analyze lymph nodes after neoadjuvant chemotherapy? And the reason is, it's very important because it does stratify survival of patients in both settings, CN0 and CN+, and actually is one of the strongest, if not the strongest, consideration and information that we can get after neoadjuvant chemotherapy. So it's important because it does give us information about survival. The second question is why it is so important to consider avoidance of axillary node dissection in this setting. And the answer is neoadjuvant chemotherapy is associated with an increase and an excess of lymphedema in this setting. And the mechanism is quite intuitive because chemotherapy destroys cells, causes necrosis, causes fibrosis, both in lymph nodes and in lymphatics, more or less as we surgeons do. And the adding effect of chemotherapy, surgery, and maybe radiation therapy can give an excess of lymphedema. The third question is, well, maybe if we remove more lymph nodes in these patients, we can improve survival somehow. And the answer is no. This has been demonstrated in a very elegant way by the Cancer Registry in Germany, 2,700 patients, multivariate analysis. There is no hint that removing more lymph nodes in these patients is associated with an improved survival. International guidelines are very different around the world. ASCO recommends a sentinel lymph node biopsy in these settings. At least 3 lymph nodes have to be removed, possibly with a double tracer. Then there is a variety of recommendations, the NCCN, ESMO, Spain, Germany, Italy, in which sentinel lymph node, eventually with a double tracer, eventually with the removal of a clip, is be considered like a TAD, as was mentioned also yesterday. And some countries, like in France or in England, which no specific recommendation were issued. What is the best technique to analyze and stage the axilla in the CM plus post-neoadjuvant chemotherapy CN0 setting is a matter of preference. And there are very good groups, like in Italy at the European Institute, and Dottoressa Galimberti has been the first one that demonstrated that sentinel lymph node in this setting can be used with very low regional recurrences. But for instance, at Memorial Sloan Kettering, they're very strong in considering the double tracer and at least 3 lymph nodes. And north of Europe and Houston and MD Anderson, they're very strong in recommending TAD. Be that clear, it's not a matter of an advantage in terms of regional relapses. Whatever technique you use, regional relapses are basically the same, as demonstrated in this retrospective study of 25 centers, more than 1,000 patients. Irrespective of the technique you use, your regional recurrence rate is less than 1%. The true question comes then in considering if the sentinel lymph node or the clip lymph node are the same lymph node. And recently, a systematic review and analysis showed this data. And the data is that the sentinel lymph node and the clip lymph node are not the same lymph node in an excess of 25% of cases. That means that 1 out of 4, or 1 out of 3 patients, we are getting 2 lymph nodes and 2 information quite different between them. And in an era of precision medicine, precision oncology, maybe we surgeons would like to be precision as well, precise as well. The second consideration is that the false negative rate of a sentinel lymph node is quite high in all studies, in excess of 15–20%, and the false negative rate of the clip lymph node is quite low, maybe 2–4%. Since then, there was another study published in Literature. This is the Danish breast cancer study group, a multi-center cohort, and you can see the stratification of this information. Again, in red, 25% of cases were not the same lymph node. My group published independently, more or less in the same period, the same data, and look at the percentages are exactly the same. We didn't know about them, they didn't know about us, and so something must be true that 1 out of 4 cases, the sentinel lymph node and the clip lymph node are not the same. I acknowledge the fact that removing a clip lymph node was quite difficult at the beginning because you had to put, for instance, a wire in the axilla of these patients maybe a few hours or 1 day before. And this could be very difficult, discomfort for the patients and so forth. But nowadays, now we know that we can put a magnetic clip, for instance, or a tag, which can be retrieved by a probe, and this can be quite useful and very easy to be accomplished. I would like to report also an interesting experience because we talk about high risk and difficult patients and difficult problems, sometimes theoretically, but what happens real world? And This is a retrospective study, real world, about 26 centers in Italy, a Senonet project, quality project that was published last year. And the objective of the study was to find out in which cases we used to do neoadjuvant chemotherapy, the trends of neoadjuvant chemotherapy for subtypes, and determinants of surgical strategies. And that's what we found. We analyzed more than 37,000 patients over a 5 years period. And this is what happens in Italy. We remained quite surprised because we thought that neoadjuvant chemotherapy was very often used in the real world in Italy. And in fact, this is not the case. We used, in the last 5 years, between 2017 2022, neoadjuvant chemotherapy only in 10% of patients. Of course, this was stratified by subtype, was about 40–50% for HER2 positive and triple negative disease, and of course, very low for luminal A or B-like. So these are numbers to be understood and remember for meditation, because we need to improve them over time, and we are in the process of analyze further data with upgrade in the last 2 years. The second consideration of this study, which I think is quite interesting, is that in Italy, after neoadjuvant chemotherapy, we use breast conservation in about 50% of cases, and this has not been improved in the last 5 years. And in the same setting that we showed before, we still use axillary node dissection in 2/3 of cases, and this must be improved. Finally, we recorded a huge variability among breast centers participating in Senonet, both for the implementation of neoadjuvant chemotherapy, but also for the implementation of breast conserving surgery, immediate breast reconstruction, use of nipple-sparing mastectomy in this setting, axillary lymph node dissection, removal of ±4 lymph nodes, single use or double use. Everybody does whatever the group decides, and this is partially good, but we should implement more stronger recommendations and guidelines in this setting. The third point is breast management in patients with BRCA mutation and disease. And the first consideration is surveillance for carriers in general. Can be done, but it's not tremendously effective. This is a very important study from Memorial Sloan Kettering. They put up a high-risk program, which patients were followed in a very important way. And look what they found. Even those who were followed very carefully, they had a decrease of improvement in DCIS. Most patients had T1 or N0 disease when they discovered cancer, but of course they had half of the cases with triple negative disease. Almost all of them underwent sentinel lymph node biopsy, but half of them received chemotherapy. So you can do surveillance for carriers, but with some problems, as you can see. The second consideration is how many BRCA genes do we have? Because you can see here the lifetime risk according to age for BRCA1 and BRCA2, but even for PALB2 disease, which is a moderate penetrance gene, you can see that the risk, particularly for young patients, can be quite high and in excess of the 40% lifetime. So the question comes, what happens for the moderate penetrance genes, and what is the polygenic risk score, which is one of the main field of interest in this setting. And as you can see, we have some moderate genes according to ASCO, and the polygenic risk score has been developed over more than 100 genes, other genes, except other than BRCA, in more than 100,000 women to find out a system to overcome the limits of the probabilistic algorithms that we now use. In other words, look what happens for PALB2 gene, and this is the general population risk. This is the PALB2 disease. This is the PALB2 if you have a polygenic risk score more than 90%, to indicate that it's not the single indication of one gene that gives all the information. And even for CHEK2, we can replicate the same information. And even for just familiar score, with the polygenic risk, the results are more or less the same. So there is more than the simple knowledge, positive, negative, BRCA1, BRCA2. There is something more that is coming up. Of course, when we talk about surgery, we want to consider the contralateral risk. And the contralateral risk, as we will see later on, can be quite high for BRCA1 and 2, and quite small for the other three genes, CHEK2, ATM, and PALB2. But look for PALB2, what happens if they are in the premenopausal stage, and if they are develop ER-negative disease. The numbers can be double digits, 20, 30% of 10-year contralateral breast cancer risk. On the other hand, BRCA is not one disease, even BRCA1 is not one disease, but we are identifying now different risk according to the kind of mutation. Truncating mutation, missense, frameshift, or splice. And we are developing the concept of BRCA hypomorphism, because you can have a BRCA mutation, yes, this can be pathogenetic, yes, but can carry a lower risk of disease. Local relapse, of course, is very important. If you have a cancer and you have a BRCA1 or 2 disease, this has been showed by a meta-analysis. The risk is 3 or 4 times higher at 15 years, but the overall survival is more or less the same as seen by this meta-analysis. For the contralateral risk, the meta-analysis shows that the contralateral risk is even higher. It can be as high as 7-fold long-term, and that the contralateral risk is higher for BRCA1 compared to BRCA2, 21 versus 15%. Data on survival for surgery that involves the bilateral surgery has been scarce. And there was a Canadian study on more than 400 patients in a propensity score match analysis, which showed a survival advantage, and a Dutch analysis that showed more or less the same. And this has been for a long time the only data that we had on survival. Recently, McAuliffe presented San Antonio last year the experience on 2,500 patients in 26 countries. And as you can see from this diagram, local relapses for those who had a bilateral surgery is quite low and can be higher, much higher, for those who underwent lumpectomy or unilateral mastectomy. Data on mortality is counterintuitive and has been subject of discussion internationally, because mortality was higher for those with unilateral mastectomy and lower for those who underwent lumpectomy or bilateral mastectomy. In Italy, we had this publication on the Italian experience, the Emilia-Romagna registry, on a smaller number of patients. This was an effort of Dottoressa Cortesi, and as you can see, retrospective data followed for 12 years. The advantage in terms of survival was quite high, both for contralateral prophylactic mastectomy and for bilateral salpingo oophorectomy. Last year at Sant'Antonio, Dr. Lambertini presented this multicenter retrospective study, more than 5,000 patients, very young patients, less than 40 years of age, BRCA in 2/3 of cases, mostly T2 and 0, triple negative, and they underwent chemotherapy in 91% of cases. About half of them received prophylactic mastectomy, bilateral, therapeutic mastectomy, bilateral, and half of them underwent bilateral salpingo oophorectomy, 20% neither. So they report a 42% less risk of second breast cancer and a decrease of about 1/3 on the risk of death. This has been published a few months ago on Lancet Oncology, and as you can see, the overall survival is significant in terms of advantage of surgery, and the breast vents, the curves, the varicoses in a tremendous fashion. And this regardless of a specific BRCA gene mutation. So these are the clinical recommendations, the ASCO and the SSO guidelines, and I would like to reassume them. The first is that breast cancer and pathologic variant for BRCA, they can be offered, of course, breast conservation, meaning that there must be a discussion about preventive surgery. But BRCA 1 and 2 patients warrant a major discussion on bilateral mastectomy. No recommendation for those who have moderate penetrance genes, PALB2, ATM, CHEK2, breast conservation should be offered. Patients with TP53 should be offered, for the reasons we know, mastectomy. And a nipple-sparing mastectomy can be offered in this setting. We have now data showing that the local recurrences, even in the BRCA setting, is quite low. So I have 4 take-home messages. The first one, I would suggest that breast conservation can be employed in all cases, even in high-risk setting, even for those who are triple negative whatsoever, if this disease can be completely removed with negative margins. We don't have data to show that the more aggressive surgery is important in terms of survival, or even in local recurrence-free survival in this setting. The second one is the neoadjuvant chemotherapy is still underutilized in many countries in Europe, and I would suggest in the world. And we should have surgical guidelines and quality indicator to be implemented in this setting, even at a European level. The third one is that mastectomy and the axillary lymph node dissection are still frequently used after neoadjuvant chemotherapy, but this should be changed because multidisciplinary meetings can understand and can direct therapy in a different way, with an advantage for women that most of the times are cured after neoadjuvant chemotherapy and are young. The fourth is that most women, PRCA positive and disease, are well served by surgical risk-reducing procedure, with a strong suggestion, as we have seen in the last paper presented by Lambertini, that these finally improve survival. I want to thank you all very, very much for your attention, and thank you again for this meeting.
Thank you, Dr. Fortunato. I would like to you to give us some time for questions, if that's all right. Yes? So do you have any questions from the audience? Three very hot topics. I have a whole list of questions here. Let me start off. Yes, let me just. In the era of precision surgery, I like this term a lot. And in the era that we do clip the involved node, and we know that in 1/4 of the cases, this clipped node will not be the sentinel node at surgery. How do you explain the results published by an Italian center, Dr. Galimberti, long-term results, 20 years results, that say that don't worry about clipping the node, just do a simple dye-only S&B, and 20 years later it won't matter?
My answer is clear. There is one way of saying in Italy, to salt the soap, the cooker is better than the king. That means that do whatever you want in your house if you can cook well. We had a national meeting in Italy in which they chose me and Dottoressa Galimberti to debate this issue, and that lasted more than half an hour. So I don't want to lose too much of your time, but I want to take the paper of Galimberti because about 30% of their patients had in fact more than 3 lymph nodes removed. So it was not one single sentinel lymph node. 30% of their patients had more than 3 lymph nodes removed. And 30% of their patients had radiation therapy done. So it's not a simple sentinel lymph node biopsy. The second one is just a general consideration. We all like and we all love sentinel lymph node biopsy because it changed the life of our women. But in this setting, you know what the lymph node is. You see it. You have it in your hand. And you decide to foresee this information, to apply the same method that you apply in another setting, because you do this all the time. It doesn't look like very smart to me. So you see the lymph node. You know what it's the biology. It's the tumor that decides what the sentinel lymph node is. It's not our method. The tumor has decided and has shown us what the sentinel lymph node is.
Thank you. Any questions from the audience? Come on, Lazarus.
Thank you, Prof. Thank you, Prof, very much for your presentation. So, based on your experience, I would like to ask, what is more important to you as a prognostic factor? Is it age or nodal status? What do you think?
Sorry, the first one, there was a...
According to your experience, okay, what is more important to you as a prognostic factor? Is it just the nodal status? Is it age? From what you have seen, because we all know that nodal status is the most important thing that we have in a histology report, but is it just that age? Maybe sometimes it's underestimated.
Well, nodal status is paramount. However, age is an independent factor for survival. It's quite important. So I think you should put, I wouldn't like to say one is more important than the other. I don't think this is wise. I think what we should do is to put all this information together and put up the best plan for every single patient.
Thank you. Any other questions? Can I go for one more question? Yes. So one more question. You showed to us that removing more nodes will not lead to a better survival. But does it lead to a different adjuvant treatment?
This is a too difficult question for me. But if I can answer, I would say that the time has come to go ahead. This has been so for many, many, many years, for decades. But I think biology, and think about all the analysis that we can do with the blood test, with the NGS, with the gene arrangement, and all the biology information are getting more and more important. I think as surgeons, we should do a step down and should manage this patient, because we can cure these patients more. They can have a long-term survival, and our main goal should be to cure them, but to have them live with a very good quality of life. I think I am not very convinced, and there's been, as you know, for abemaciclib and olaparib, a tremendous debate for the 4 lymph nodes, less than 4 lymph nodes. I don't think that our history is going in that direction.
Okay. Thank you very much, Prof. Fortunato. Thank you, everyone. Και θα δώσουμε το βήμα στο επόμενο Προεδρείο.